Welcome everyone. I'm Barb Kabilis. I'm the Regional Stroke Education Coordinator for Central South Regional Stroke Network. It is my pleasure to welcome Elizabeth Crawford, physiotherapist, today to address part 4 in our series, Forward Thinking about Posterior Circulation Stroke. We have the first 3 segments are posted on our website, www.csnstroke.ca, and you are able to watch them after this presentation if you like, and we will be posting Elizabeth's as well as the upcoming segments, which I'll tell you about at the end of this talk. So I'd like to introduce Elizabeth. Elizabeth Crawford is a physiotherapist and co-director at Vestibular Health, part of the Hertz Clinic for Meniere's disease and vestibular dysfunction at the UHN Toronto General Hospital. Elizabeth's area of clinical focus is vestibular and neurological rehabilitation. She has a certificate in vestibular rehab through Emory University and has advanced vestibular training through the University of Pittsburgh. Elizabeth has experience working with both community and hospital-based multidisciplinary teams focused on rehabilitation for people with neurological disorders, traumatic brain injury, balance and gait impairments, and dizziness. Welcome, Elizabeth. I'll let you take it away.
All right, thanks for the introduction, Barb. So like Barb said, my particular area of clinical focus as part of the neurology clinic at Toronto General is vestibular and neurologic rehab. And today we're going to talk about vestibular symptoms and the role of vestibular rehab strategies after posterior circulation stroke. So today I'd like to start by reviewing the peripheral and central aspects of the vestibular system. We'll talk about vestibular symptoms like vertigo, dizziness, and imbalance, particularly after posterior circulation stroke. We'll review the differential diagnosis of dizziness that's triggered by position changes. This is a really common issue both in acute and rehab settings, and in some cases can be very effectively treated. And then we'll discuss the role of vestibular rehab in stroke rehab and give you some practical suggestions on how you can integrate these strategies into the care of your patients. All right, so the vestibular system is composed of both peripheral and central components. And the vestibular system is made up of the vestibular organs in the inner ear that sense head movement and head position, and the vestibulocochlear nerve, so the 8th cranial nerve that sends information about hearing and balance to the brain. And then the areas of the brain that process vestibular information, primarily the brainstem and cerebellum. Now, our vestibular system has connections both to our extraocular muscles, so the muscles that move our eyes, and our postural muscles that process this information and keep us upright against gravity. So the primary function of the vestibular system is to maintain gaze stability, so our ability to keep our vision clear and stable, particularly while our head is moving around. And our vestibular system, of course, helps us maintain our posture and our balance and spatial orientation. So let's look at the inner ear. So the inner ear organs are encased in the temporal bone of our skull, and the inner ear is shown in purple. So there's 2 parts to the inner ear, the cochlea, the hearing part, and then the vestibular organs, which are the balance part. So zooming in to the vestibular system, the vestibular organs themselves actually have 2 parts, the semicircular canals and the otoliths. And the semicircular canals here sense head rotation or angular acceleration, right? And there are 3 canals on each side. They're paired right and left, and they're oriented orthogonally to one another. Now, the otoliths are the other part of the inner ear balance organs, and the otoliths are further divided into 2 parts, the utricle and the saccule. And this part of the inner ear senses linear acceleration and head position relative to gravity. So the utricle senses linear acceleration in the horizontal plane, and the saccule senses linear acceleration in the vertical plane. And so the otoliths sense linear acceleration, but also head tilt, or they're the gravity receptors in our inner ear. All right, so remember that one of the functions of the vestibular system is maintaining gaze stability. And this is the function of the vestibulo-ocular reflex, or the VOR. So this is what allows us to have clear and stable vision during head and body movements. And normal function of our VOR really does require our peripheral vestibular system, our eighth cranial nerve, and our central vestibular system to be intact and working properly for us. Now, the VOR is actually modulated by the cerebellum. So how the VOR works is that the semicircular canals, particularly in our inner ear, sense rotational or angular acceleration, and these sensory signals are transmitted through the vestibular nerve to the vestibular nuclei in our brainstem. And this generates a coordinated motor response from our extraocular muscles. And this allows our eyes to move in an equal opposite direction to head movement. So if I want to keep my eyes focused and forward on a target, as I move my head one direction, my eyes actually have to move the equal and opposite way in the other direction. So we clinically evaluate the function of the vestibulo-ocular reflex using the head impulse test or the head thrust test. And so what we do in this test is we ask the patient to maintain visual fixation on a target, and we passively rotate their head in a small range of motion, but with rapid speed. And moving the head to the right tests the right horizontal semicircular canal, the VOR function on the right side, and moving the head quickly to the left tests the left side. And when the VOR is functioning normally, when we move the patient's head quickly, their eyes maintain fixation on the target. And a positive or an abnormal test is when the patient's eyes first move with the head, and then there is a corrective refixation saccade back to the target. So this compensatory saccade, if you see that, that's a positive test, and that indicates hypofunction of the VOR on the side you're testing. So let me play this video here, and you can see with this patient, when his head is moved quickly to the right, his eyes slide off the target, and then there is a corrective saccade back to the target. That's a positive head impulse test to the right, indicating right VOR hypofunction. To the left, his eyes stay on target, so that's a normal test. Okay, so remember that the other key function of the vestibular system is to maintain a balance and postural stability. And the vestibulospinal reflex is important to this aspect of vestibular function. So our semicircular canals and our otoliths sense head tilt, and these sensory signals are sent through the vestibular nerve to the vestibular nuclei in the brainstem, and then on via the vestibulospinal tracts to our spinal cord. And this generates extensor muscle activity on the side to which our head is inclined, and flexor activity on the opposite side. So that's the vestibulospinal reflex. We also have cervical vestibular reflexes, so the vestibulocolic reflex that helps stabilize our head, and our cervical ocular reflex, which describes eye movements that are driven by neck proprioception. So the sensory signals from our semicircular canals and our otoliths enter the brainstem through the eighth cranial nerve at the junction of the pons and medulla. And this generates a reflex motor response in the extraocular muscles, the vestibulo-ocular reflex. And it also generates postural muscle responses, so the vestibulospinal reflex. Now, vestibular information is also relayed to the cerebellum. So the cerebellum, the vestibulocerebellum specifically, receives input from the vestibular nuclei. And the vestibulocerebellum is comprised by the flocculonodular lobe and the adjacent vermis, right? So the flocculus, the nodulus, and some areas of the vermis are what we refer to as the vestibulocerebellum. Now, the vestibulocerebellum is really important for gaze holding, for smooth pursuit, for the ability to suppress or cancel our vestibulo-ocular reflex, and it also mediates adaptation of the VOR. So what do I mean by VOR cancellation? Well, in some circumstances, we actually want to suppress our vestibulo-ocular reflex. And how clinically we evaluate the ability to suppress the VOR is actually with a VOR cancellation test. I'll demonstrate that. So I'll bring my hands in front, I'll look at my thumbs, and as I move side to side to keep looking at my thumbs, I actually need to suppress my vestibulo-ocular reflex. So that's VOR cancellation. And what do I mean by mediating adaptation of the VOR? So one relatively simple example of that is if you wear glasses and you get an updated prescription, a new set of lenses, your VOR actually has to be fine-tuned to that new prescription. So our VOR can be adapted, and that's the function of the vestibulocerebellum. Now, if we have dysfunction in the vestibulocerebellum, this leads to gaze-evoked nystagmus, particularly bidirectional or bilateral direction-changing gaze-evoked nystagmus, so a left beat nystagmus in left gaze, right beat nystagmus in right gaze, or it could lead to downbeat nystagmus in lateral gaze. And dysfunction in the vestibulocerebellum also leads to saccadic smooth pursuit and the inability to suppress the vestibulo-ocular reflex. So that is the peripheral and central aspects of the vestibular system. How does that relate to posterior circulation stroke? Well, the vestibulocerebellum and the inner ear itself are actually supplied by the posterior circulation. So chiefly the posterior inferior cerebellar artery, the anterior inferior cerebellar artery, and actually the labyrinthine or internal auditory artery is a branch of the anterior inferior cerebellar artery, and this internal auditory artery is actually what supplies our inner ear structures and our eighth cranial nerve. All right, so anterior inferior cerebellar artery, or ICA, this supplies both peripheral and central vestibular structures. Remember that the internal auditory artery is a branch of the ICA. It supplies the vestibulocochlear nerve, the cochlea, and the vestibular labyrinth, or the vestibular end organs themselves. And so an ICA infarct leads to a combination of peripheral and central signs and symptoms. So it leads to vertigo, hearing loss, gait ataxia, dysmetria, central oculomotor signs like impaired smooth pursuit and gaze-evoked nystagmus. And it can also lead to a partial ocular tilt reaction, so ocular torsion and skew deviation, and also a deviation of subjective visual vertical. And this happens particularly if there's an infarct of either the inner ear itself or the root zone of entry of the eighth cranial nerve, so at the junction of the pons and the medulla. So an infarct of the posterior inferior cerebral artery, so a pica infarct, of course, leads to lateral medullary or Wallenberg syndrome. And I'm not going to review all the features of Wallenberg syndrome today. I know other speakers in this series have talked in more detail about that. But in relation to vestibular dysfunction, the medial branch of the pica in particular supplies the inferior vermis and the nodulus. And remember that the nodulus is critical to modulating the VOR. So infarct of the pica, the medial branch in particular, leads to vertigo, nausea, vomiting, postural instability, and lateral pulsion. So an acute vestibular syndrome of vertigo, nausea, and ataxia, of course, can be a presenting symptoms of a posterior stroke, but they can also be due to an acute peripheral vestibular loss, such as with a vestibular neuritis. And I know other speakers in this series have presented on acute diagnosis and management of posterior stroke, so I'm not going to discuss this in detail today. I'd like actually to stick to talking about the rehab phase. So in the rehab phase, taking a good dizziness history can help you understand the symptoms that your patient is experiencing, and this can be really important in both helping you determine a vestibular diagnosis and also to guide your interventions. So their description of their symptoms, as well as how often they're happening, how long the symptoms last, If there's any particular triggers, aggravating or easing factors, can be really helpful in guiding your assessment and your interventions. So let's talk a little bit about some of these symptoms. Now, dizziness is probably the one that your patients are going to tell you about most commonly. That's the word that they'll use to describe it, but it really is a very non-specific term. And the word dizziness encompasses many, many different sensations. So it could be a feeling of lightheadedness or a presyncopal type feeling. It could be a more off-balance sensation. People could be using this word and describing true vertigo. So it is a non-specific term, and people do sometimes have a hard time describing the sensations they're experiencing. And one thing that can be helpful when you are taking a dizziness history is to ask your patient something like, if you couldn't use the word to describe the feeling, if you couldn't use the word dizzy to describe what you're feeling, how would you say you're feeling? So asking them to find some alternative descriptors can sometimes be helpful. Now, where dizziness is a non-specific term, when we're referring to vertigo, we are referring to a very specific symptom, and that is a false sense of movement. So an illusion or hallucination of movement of either oneself or one's surroundings. And so this can be a feeling as if you are moving or the environment is moving. And this is often a spinning or rotational sensation. So patients might tell you they see the room turning around, but it's not always rotational. So patients can experience non-rotatory vertigo, so a feeling of swaying, dropping, shifting side to side. And depending on the cause, vertigo or any symptoms of dizziness might be triggered by head movement or position changes, or they may happen completely spontaneously. And if vertigo is due to some inner ear conditions, it can come along with or be associated with more hearing-related or ear-related symptoms like hearing loss or fluctuation, ringing or other sound in the ears, and pressure or fullness in the ear. So disequilibrium is really just referring to unsteadiness or imbalance. And we often hear our vestibular patients say something like, people must think I'm drunk. Often with vestibular disorders, the feelings of imbalance or unsteadiness are worse with movement, particularly worse with head movement. And they're usually best when people are stationary or completely not moving or completely still. Now, patients sometimes also describe feelings of being pushed or pulled in a certain direction. They may have an altered perception of vertical or may actually have a head tilt or body leaning over to one side. And this lateral repulsion or altered perception of verticality from a peripheral origin can be due to otolithic dysfunction. So remember, the otoliths are the linear acceleration and gravity receptors in our inner ear. So dysfunction in this part of the ear can lead to lateral repulsion or feelings of altered sense of vertigo. Now, we see lateral repulsion, of course, more substantially post-stroke with Wallenberg syndrome. And with a Wallenberg, the lateral repulsion is ipsiversive, so towards the side of the infarct. And there's both abnormal subjective visual vertical and abnormal sense of postural vertical. And so this is in contrast to, for example, a post-stroke pusher syndrome, where the pulsion is generally controversive, so away from the side of the lesion, but towards the hemiparetic side. And in pusher syndrome, this is due to an abnormal postural vertical and usually some degree of spatial neglect. But in a pusher syndrome, the subjective visual vertical remains intact. So in a Wallenberg, the subjective visual vertical and postural vertical are both affected, as well as the vestibular system being affected. And in pusher syndrome, usually the visual and vestibular inputs are intact. So there are some symptoms that are more visually related that can actually be a result of vestibular dysfunction, and oscillopsia is one of these. And so this is describing blurry or unsteady vision, particularly with head or body movement. And we do have some of our vestibular patients who experience oscillopsia describe a feeling of a lag, like their eyes don't quite keep up with their head movement. They might also describe bouncing, bobbing, or blurry vision when they're walking. And another example is patients may say as they're walking, if they're walking down the hallway, they can't read the signs on the wall. They have to stop in order to read them because the text is blurry or moving around. Now, if this oscillopsia is related to head or body movement, it is most likely due to an impairment of the vestibulo-ocular reflex. So the eyes are not able to stay on target while the head and body are moving around. Now, if oscillopsia is happening when somebody is completely stationary, it's not associated with head movement, that could be due to nystagmus. So if someone, for example, has an acute or new onset of spontaneous or gaze-evoked nystagmus, of course they may experience unstable vision because their eyes are actually moving. Now, another vision-related symptom that can potentially have a vestibular origin is visual motion sensitivity. You might also hear this referred to as visual vestibular mismatch. And really, this is just describing dizziness or intolerance to complex visual stimulation. For example, difficulty tolerating scrolling on a screen, watching a TV show where there's lots of action, an intolerance for visually busy patterns or environments. Now, this symptom tends to be less common after stroke and more common after traumatic brain injury. So another really common occurrence, both in acute and rehab settings, is dizziness with position changes. Now, of course, postural or orthostatic hypotension is a common cause of dizziness with transitional movements, for example, or in particular, lying to sitting up or sitting to standing. So, of course, blood pressure changes can have an impact on feeling dizzy as you change position. But there are a few elements of the patient's history that should raise suspicion for Bppv. So that's benign paroxysmal positional vertigo. And Bppv is quite common and it is typically very effectively treated. It can cause people to have substantial imbalance along with positional vertigo, and treating their Bppv can really help decrease their risk of falling and can improve their engagement in their therapies and in their rehab. So I'd like to talk a bit about Bppv and then touch briefly on central positional nystagmus. And the reason for talking about central positional nystagmus today is even though it is much less common than Bppv, it actually can be a result of posterior stroke. So I thought it would be worth mentioning that today. So benign paroxysmal positional vertigo is the most common cause of vertigo in adults. And even though it is relatively common, it unfortunately is rather under-recognized and undertreated. It's been estimated that about 20% of all dizziness that's seen in medical consultation is actually due to Bppv, and about 40 to 50% of all dizziness that older adults experience is due to Bppv. Unfortunately, only about 10 to 20% of patients who have Bppv seen by a physician get appropriate treatment for it. So idiopathic Bppv is much more common with older age. The peak incidence is actually between the age of 50 and 80 years, and above age 60, the estimated annual prevalence of Bppv is 3.4%. Now, under age 50, the most common cause of Bppv is actually head injury, and we would refer to that as post-traumatic Bppv. But post-traumatic Bppv can also happen in people, for example, who have balance difficulties post-stroke and they fall and hit their head, or if they fall and strike their head in the course of their acute stroke, or related to, for example, seizures or a syncopal episode. And the other thing you may see is people who are in rehab post-stroke who have Bppv that's actually unrelated to their stroke. It's just never been appropriately recognized or treated. Treating their Bppv can really have a positive impact on their participation in therapy, reduce their risk of falls, and improve their balance. So the symptoms of Bppv happen in a characteristic pattern. And it is typically vertigo that occurs in recurrent spells that last less than a minute, and in many cases last less than 30 seconds at a time. And this is often, but not always, a feeling or seeing the room spinning. So here's the thing: that's the classic description of it is episodes of vertigo lasting less than a minute that are the room turning around. But not everybody who has Bppv describes the room spinning or describes rotatory vertigo. I've had patients who describe sort of a vague sense of lightheadedness and nausea. They're slightly off balance. I've had patients use the word giddiness to describe their symptoms. And on evaluation, we do determine that those symptoms are actually caused by Bppv. So it's not always rotatory vertigo. Now, these spells are all triggered by changes in head position relative to gravity. And so the classic presentation would be these short spells of vertigo with lying down, from sitting to lying down in bed, with turning or rolling over in bed, with bending forward, or with looking up. But these spells could also be triggered with getting up from lying down, with rising up from a bent over position, or with turning the head. Now, these spells are often associated with nausea, sometimes vomiting, often with substantial imbalance or motion sensitivity, and the feeling of vertigo is often quite anxiety-provoking for people. So what causes Bppv? So we have calcium carbonate crystals called otoconia that are actually embedded in our otoliths, embedded in the utricle and the saccule. Now, if those otoconia become dislodged from the utricle, they can migrate into the semicircular canals, and this causes the semicircular canals to be abnormally sensitive to gravity. So head movements relative to gravity cause the crystals to move in the fluid in the canals. And this causes an abnormal stimulation of the canal, which sends a false signal to the brain and the eye muscles. This causes nystagmus and vertigo. So to determine if a patient has Bppv, we evaluate for symptoms and nystagmus with positional testing. And the Dix-Hallpike shown in this video here is considered to be the gold standard for diagnosis of posterior canal Bppv. In the Dix-Hallpike maneuver, we rotate the patient's head 45 degrees, then move them from sitting to supine with their head extended 20 to 30 degrees below the horizontal. And if there's crystals in the canal, they'll move in the fluid in the canal as we do this maneuver, which causes symptoms and nystagmus. And if the crystals are moving in the posterior canal, we'll see upbeating torsional nystagmus. Now, posterior canal Bppv accounts for 85 to 95% of cases. The other 5 to 15% of cases is Bppv in the horizontal canal. And if we see horizontal nystagmus in the Dix-Hallpike maneuver, then we evaluate for Bppv in the horizontal canals using the maneuver shown in this video here, the supine headroll. And so the patient's supine with their head slightly elevated to place the horizontal canals into the vertical plane. And then the patient's head is turned to one side. We observe for symptoms of nystagmus, and we test the other side as well. And what we're looking for is the direction and duration of the nystagmus to tell us what side, which ear is affected, and whether the crystals are freely floating in the canal or if they're stuck down. Now, here's a video example here of upbeating right torsional nystagmus during a right Dix-Hallpike. And so this tells us that the crystals are moving in the right posterior canal, so it's right posterior canal Bppv. So we closely evaluate the eye movements during positional testing, so we're looking for the duration and direction, particularly of the nystagmus, and this allows us to determine which ear and what canal is affected. So if somebody has Bppv, we treat it using physical maneuvers, using head position and gravity to move the crystals out of the canal and back into the utricle. And so these maneuvers are specific to the side and the canal that's affected. And the one that you might already be familiar with is the Epley Maneuver. That's the one in the picture here. So this treatment maneuver starts actually in the same position as the Dix-Hallpike assessment on the affected side, so the head turned 45 degrees and then extended 30 degrees below the horizontal. And the head is then rotated 90 degrees to the opposite side, and then a further 90 degrees with the patient moving into a side-lying position with their head turned down 45 degrees from the horizontal. And then the maneuver ends by the patient sitting up slowly. And we hold each position for 30 to 60 seconds, or at least twice the duration of the nystagmus that we observe. Now, if the crystals are in the horizontal canal, we need to do a different maneuver, and the one shown here, the Lempert or barbecue roll maneuver, is the most commonly used. Now, there are alternative repositioning maneuvers, for example, if patients have neck range of motion limitations. And some treatment maneuvers may require more than one provider to assist with the movement, particularly if patients have difficulty with bed mobility or transitional movements. It can also be helpful to have a bed or a plinth that has a movable head section to help support the patient. So there is strong research evidence that Bppv treatment maneuvers are safe and effective, and we have a clinical practice guideline that provides recommendations for evidence-based care. And the treatment success rate of these maneuvers is actually very good, somewhere in the order of 80 to 90%. And for some people, a single treatment session completely resolves their symptoms. And one thing to note is we can do multiple assessment and treatment maneuvers within a single session if the patient is able to tolerate that, and that can increase the likelihood of resolution within that single treatment session. Now, not all positional nystagmus or vertigo is due to Bppv. So another possible cause of positional nystagmus is actually central positional nystagmus or central positional vertigo. And this occurs in a different pattern from Bppv. So usually it is a vertical nystagmus without any torsional component. It is very persistent, so with Bppv, the nystagmus usually crescendos and then decrescendos over the course of that 30 to 60 seconds that it's present, but central positional nystagmus, the nystagmus will go on for longer than that. And this nystagmus, when it is of central origin, doesn't fatigue with subsequent attempts at assessment or treatment maneuvers. And of course, central positional nystagmus is not going to respond to Bppv treatment maneuvers. And in some cases, the patient is only mildly symptomatic or asymptomatic, even though you're observing nystagmus in these different positions. So the cause of central positional nystagmus is actually lesions in the cerebellar nodulus or uvula, and this, of course, could be due to stroke, but also could be related to Chiari malformation, cerebellar degeneration, a tumor, or multiple sclerosis lesions. All right, so I'd like to shift a bit here and talk about vestibular rehab, so what it involves, the evidence supporting its use, and some practical suggestions on how you could integrate vestibular rehab strategies into stroke rehab. So vestibular rehab is really an exercise-based form of therapy. It's usually delivered by physiotherapists, but you may see audiologists or other allied health providers providing vestibular rehab. And the primary aim is, of course, to improve problems that are caused by vestibular disorders. So our goals are to reduce symptoms of vertigo and dizziness, to improve gaze stability, to improve balance and mobility, and overall reduce people's risks of falls. And our initial vestibular rehab assessment looks very similar to a physiotherapy assessment in other areas of practice, particularly neurological rehab. So we, of course, start with a clinical interview to better understand our patient's symptoms, their functional limitations, and their goals and priorities. And we focus specifically on balance and dizziness-related concerns. And we do use a number of questionnaires related to dizziness and balance, including the Dizziness Handicap Inventory, the Activity-Specific Balance Confidence Scale, and these actually may be some helpful self-report measures to use as an outcome measure in patients post-stroke who are experiencing dizziness. In terms of our physical examination, we perform, of course, clinical tests of both peripheral and central vestibular function. So tests of the vestibulo-ocular reflex, like the head impulse test that I mentioned earlier. And the clinical tests of central vestibular function, of course, are focused on cerebellar functions. So an oculomotor assessment, the ability to suppress the VOR and coordination tasks. We, of course, do positional testing for Bppv and perform other standard aspects of a physiotherapy, neuromusculoskeletal exam, depending on what's most relevant to that patient's presentation and their symptoms and functional goals. We evaluate static balance under different sensory conditions. We evaluate gait and dynamic balance in actually many of the same ways that these are assessed in neurologic physiotherapy. Now, if a patient is experiencing motion-provoked symptoms, we may perform a standardized assessment of motion sensitivity to track change over time. So the motion sensitivity quotient is one of those measures shown here. Now, for some patients, this can be a bit time-consuming to do this evaluation, and for some people, it is not well tolerated because it involves a lot of motion if they are quite sensitive. So a non-standardized measure that you could use to assess this is actually to select just the movements that are most relevant to your particular patient. For example, if they're really bothered by head turns, have them do that movement in a standard way, record the amount of time it takes for their symptoms to settle back down to baseline levels after the movement, and have the patient rate the intensity of their symptoms. So this could be a way of monitoring whether you're making gains with rehab. So in vestibular rehab, our treatment, of course, includes Bppv maneuvers if the patient has Bppv. And if someone's experiencing repeated recurrences of Bppv, we may instruct them or their family on how to support them in doing these maneuvers safely and effectively on their own at home. We would give them instruction on how to do the maneuvers correctly, when they should be performing the maneuvers, and when they should seek follow-up care with a healthcare professional. If an individual has VOR impairment or loss, we would include gaze stability exercises to facilitate adaptation of the VOR, and I'll talk a little bit more about these in a moment. When there's motion-provoked symptoms or visual motion sensitivity, we would include habituation exercises to gradually desensitize and build tolerance for the provoking movements. We, of course, include gait and balance training, general strength or reconditioning exercises as indicated, education around falls prevention, gait aid prescription if needed, and assist in functional goal setting. So vestibular rehab exercises don't regenerate a damaged vestibular end organ or vestibular nerve. We're not trying to get a change in the inner ear itself. Our goal is to facilitate an adaptive response, so to drive central compensation for vestibular loss. And like other areas of neurologic rehab, we're trying to facilitate neuroplastic change. And we often describe this to our patients that we're trying to train the brain to recalibrate how it's interpreting vestibular signals and how it's generating eye movement and postural responses. And particularly when it comes to adapting the VOR or building central compensation for VOR loss, gains sometimes can be slower in folks who have central vestibular disorders. And again, this is because the cerebellum is important in modulating the VOR. So we do have moderate to strong evidence based on high quality randomized control trials that vestibular rehab is safe and effective as a treatment for peripheral vestibular hypofunction. And for Bppv, yes, we have strong evidence for treatment maneuvers, but we also have evidence that a combination of the treatment maneuvers and vestibular rehab exercises is more effective for longer term functional recovery. We do have a clinical practice guideline that outlines the evidence in support of vestibular rehab for both unilateral and bilateral peripheral vestibular hypofunction, and some best practice recommendations around exercise prescription. Now, for the use of vestibular rehab in neurologic disorders, the evidence is emerging. And there are fewer and lower quality studies. There's more heterogeneity in the patient population and actually the interventions themselves in these studies. A recent systematic review of vestibular rehab in neurologic disorders actually included studies of patients with traumatic brain injury ranging from mild to moderate, MS, Parkinson's, and stroke. And there was some evidence that vestibular rehab was safe and provided benefit with respect to particularly balance outcomes when administered in addition to standard neurologic rehab programs. Now, specifically looking at the evidence for vestibular rehab post-stroke. So there's a systematic review that reviewed the effects of vestibular rehab on gait in stroke, and there were only 3 randomized control trials identified by this review. 2 of the 3 studies did show benefit or additional benefit of vestibular rehab over usual care in measures of gait and balance. However, the sample sizes of these studies were small. Looking at stroke and dizziness, there was a pilot randomized control trial published in 2020 that investigated the use of vestibular rehab in people with stroke who were also experiencing dizziness. And this compared usual care to usual care plus vestibular exercises. And the authors did publish their complete intervention protocol in this study. And it included balance exercises involving head and eye movements, eyes closed, compliant surfaces, but didn't include any gaze stability exercises. Now, this study didn't demonstrate a significant difference between usual care and usual care plus vestibular rehab, and the authors suggested this could be due to small sample size. And one limitation of this study as well is they didn't consider the site of the lesion or the ultimate cause of the person's dizziness. They did conclude, though, that their intervention in this pilot study was feasible and there was high adherence to the intervention. So, although it's based on a small number of randomized control trials and several studies that have less rigorous designs, there does appear to be an overall positive trend for improvement in measures of balance, of gait speed, balance confidence, and perceived dizziness with the addition of vestibular rehab exercises to usual care in people with stroke. And despite the limitations of our current evidence base, I hope you can see how vestibular assessment and treatment strategies could be relevant in this patient population. So older adults are both at increased risk of stroke and increased risk of vestibular dysfunction, both Bppv and age-related dysfunction in vestibular pathways. And one thing to consider is that if an individual at baseline prior to their stroke has any peripheral vestibular dysfunction, that they may have pre-stroke had that vestibular dysfunction and actually had good central compensation for it. But then if they have a stroke affecting the cerebellum, they may lose their central compensation and be hit with both this peripheral and central vestibular loss. Overall, vestibular rehab exercises do seem to be a safe and feasible addition to usual care, and they may provide additional benefit. And they may be particularly relevant if somebody has a simultaneous or prior peripheral vestibular dysfunction along with their stroke, or if their stroke is affecting central vestibular pathways. So some potential barriers to including vestibular exercises, particularly in the subacute or early rehab phase, is how easily symptoms can be provoked in some individuals. So the types of exercises we might use, one example is gaze stability exercises. So for these gaze stability or VOR adaptation exercises, we place a visual target, usually on the wall. I know in the video here it's showing a handheld target. And we have the patient move their head while they're maintaining visual fixation on the target. And we ask the patient to move their head as quickly as they're able to tolerate, as long as they perceive the target to stay clear, in focus, and stable, so not moving around. And these gaze stability exercises are particularly indicated if there's a deficit in the vestibulo-ocular reflex, or if they are sensitive to head movement and you're trying to habituate or desensitize to these head movements. So these exercises would be particularly indicated if there's a positive head thrust or abnormal dynamic visual acuity on your physical examination. The purpose of these exercises is to facilitate central compensation for the VOR loss, and they are quite effective with a peripheral vestibular loss. Clinically, we do see gains in people who have a cerebellar dysfunction. With respect to VOR adaptation, however, these gains are often a little bit slower and perhaps less complete than we would see with a peripheral vestibular loss. Habituation exercises are used if the patient's experiencing motion-provoked dizziness. So these exercises really are individualized to the particular patient's symptoms and tolerances. However, some examples might be head movements, bending down and up, sit to stand, sitting and bouncing on a Swiss ball. And the role of these exercises is to provide gradual and repeated exposure to build tolerance to the provoking movements or environments. Now, a vestibular rehab approach to balance training really involves considering sensory interaction. So the visual, vestibular, and somatosensory contributions to balance. So we do, of course, vary the base of support, include both static and dynamic tasks, but balance training from a vestibular perspective really should involve some head movement to challenge the vestibular system. We ask people to close their eyes during their balance tasks to remove visual inputs and increase the demand on the vestibular and somatosensory systems. And we use compliant or unsteady, unstable surfaces as well to further the level of challenge by modifying the somatosensory inputs. So an example of that would be standing on a foam pad. And we use combinations of head movements, closing eyes, and unsteady surfaces to increase the level of challenge as adapted to that client's abilities and tolerances. So, for example, we may have the patient stand on a foam pad, close their eyes, and move their head, and this really places a high demand on the vestibular system. The other thing to think about with balance training is it actually needs to be challenging enough to drive an adaptive response. So we do need to provide instructions to patients on how to perform balance exercises safely, especially if we're giving these as part of a home or independent exercise program. So we do want our patients to be safe when they're doing their balance exercises, but we do need to generate some balance responses. They do need to be somewhat challenging in order to facilitate change. So most of us are familiar with asking for a rating of perceived exertion during, for example, cardiovascular exercise, but we don't usually ask people how challenging they perceive their balance exercises to be. And of course, we observe their balance reactions and we make a clinical judgment regarding the level of challenge, but getting a subjective rating of difficulty can be helpful in exercise prescription. And it can also be helpful when providing education to our patients that their exercises do need to be at least moderately challenging in order to improve their balance abilities. It also helps us provide some reassurance to patients that, that if they're experiencing balance reactions during their balance exercises, it's actually a good thing. And people do get frustrated when they feel they're not doing their balance exercises well enough. Providing some education that they do actually need to be challenging and generate balance responses to make a change can be helpful in reducing your patient's frustration level with their balance exercises. So let me summarize a bit here. So vestibular symptoms are common, of course, after posterior circulation stroke. And with posterior stroke, you can see a mix of peripheral and central vestibular signs. So an ICA stroke in particular can result in a mix of peripheral and central vestibular dysfunction, right? So a branch of the ICA does provide as blood supply to the inner ear structures themselves. We can see peripheral vestibular signs also when the root entry zone of the vestibulocochlear nerve is affected. So that's at the junction of the pons and medulla. And one thing to keep in mind is that individuals might have vestibular dysfunction at baseline prior to having a stroke, and that could make them more vulnerable to having dizziness and balance problems after a cerebellar stroke. Bppv is relatively common and can be very effectively treated. And if patients have symptoms lasting less than a minute with head position changes relative to gravity, you should suspect this and provide assessment and treatment if indicated, or refer to a provider who can. Treating someone's Bppv can have a really positive impact on their balance and reduce their risk of falling. Vestibular rehab does seem to be a reasonable addition to usual care during stroke rehab, and it can provide additional benefit for people who have dizziness post-stroke. It may help improve gait and balance outcomes. And this could involve gaze stability exercises for people who have a VOR impairment, habituation exercises if they have motion-provoked symptoms, and balance training that considers challenging the vestibular, visual, and somatosensory systems. All right, so I think we have some time for questions. I'm just going to stop my share here.
Thank you, Elizabeth. I learned a lot from that presentation. I hope others did as well. I have one question so far in the chat from Monica. Monica is wondering if you know if there is a list of therapists or clinics in different areas of the province that are qualified to provide vestibular exercises.
Good question. Okay, so it can be tricky in some areas of Ontario to find a vestibular rehab provider. Generally, you're looking for a physiotherapist who has additional postgraduate training in vestibular rehab. Often, but not always, that means going and doing the certificate course in the US through Emory and Duke universities. That is sort of the most common certificate that you'll find people will have out there. Your best bet is to try and find a physiotherapist or a clinic whose primary focus is vestibular rehab or vestibular and neurologic rehab if you're seeing patients post-stroke. And if you're having trouble, send me an email and I'll see if I can connect you to somebody locally that our clinic might be aware of.
Great. I have another question from Mandeep. Is it safe to provide vestibular rehab to stroke patients with visual impairment?
So I think it would be safe to provide that, but it can be difficult to tease out what their dizziness and balance complaints are. Is it due to an impairment in the vestibulo-ocular reflex? Or is their impaired vision having an impact on that? And it can sometimes be tricky for folks to do gaze stability exercises when they do have visual impairment because you're asking them to focus on a visual target. So I think my answer is it's probably safe, but it might, what you choose to do might depend on what the patient's actual visual impairment is.
Thank you. From Jumana, if a patient is wearing an eye patch, do you take it off during gaze stability exercises?
That is a great question. Okay, so whether it is an eye patch or glasses or whatever else they might be using, I usually instruct my patients to do their vestibular exercise, so their gaze stability exercises, using whatever they wear in their day-to-day life. So remember, our VOR is fine-tuned if we change our glasses. So I ask the patients, if you wear your glasses full-time, do your exercises wearing your glasses. If you wear an eye patch full-time, do your exercises wearing your eye patch. That's usually my suggestion to patients. Sometimes it will depend on what they can tolerate. Most people will have a patch because they're experiencing some degree of double vision, and gaze stability exercises are quite hard for people to do if there's they have double vision and they have to pick a target to look at. So my suggestion would be, if they're wearing their eye patch full time, leave the eye patch on for the gaze stability exercises.
Thank you. Is it expected that the gaze stability exercises will cause some dizziness for the patient?
Yes, it is expected that the gaze stability exercise, if somebody is sensitive to head movement, would cause some dizziness. And so this is where you really need to individualize your prescription of these exercises to the particular patient that you're seeing. Some patients are not that bothered by it. They're not that dizzy with it. Some people really are quite, their symptoms are quite provoked quite strongly. So usually we try and prescribe these exercises so patients might experience a mild to moderate increase in their dizziness, and that would settle back down to baseline levels within 15 or 20 minutes or so. And we definitely, when we're prescribing these exercises, tell people that they can make them dizzy. And we try and provide education that these exercises will make you dizzy temporarily right now in the short term to address your dizziness, gaze stability, and balance impairment in the long term. And sometimes we use the analogy of if you are doing exercises to build your strength, you're doing some weight training, sometimes your muscles might feel a little bit sore. It feels like the weights that you're lifting are heavy. We sometimes use that analogy when we're talking about training for improving dizziness symptoms, is saying we're going to push into it a little bit per your tolerance level. But yes, these exercises can make you dizzy. We're trying to promote a long-term change and improvement in your symptoms.
Great. I'm loving these questions. Keep them coming. Here's another one. Can you explain causes for person-centered spinning as compared to environment-centered spinning?
Yeah. So I think everybody perceives, especially if we're talking about, say, vertigo triggered by a spell of Bppv, people experience this vertigo in really many different ways. And I think the difference between what people experience is their own interpretation of what they're feeling, their ability to express that, and how their nervous system is responding to it. So I think the ultimate cause can be the same, but people describe it or experience it in different ways. I hope that answers the question.
Thank you. Someone asks, where is your clinic?
Yeah, so Vestibular Health is located in Toronto. We're based out of Toronto General Hospital in the neurotology head and neck clinic there. And you can find us at vestibularhealth.ca for more details.
Thank you. Two more questions. Do you treat COVID long haulers as vestibular patients? Pushing through it slightly is in the brackets, or ABI post-concussion patients and stop when they feel dizzy or nauseous when you're doing rehab with them. So you treat the COVID long haulers or the ABI post-concussion?
Okay.
And how helpful is the vestibular rehab for them, especially if they have a bilateral normal head thrust test? Sorry, that was a two-parter.
Okay. All right. Let me wrap my head around how to answer this one. Okay. So I guess the question is if somebody is having vestibular symptoms, persistent vestibular symptoms post-COVID, so COVID long haul symptoms of COVID, including vestibular symptoms. I think that's the question. Clarify in the question or the chat if I haven't got it quite right. And I think it depends on the patient's tolerance level, and it depends on what you're trying to address. So if their head thrust is normal on both sides, their dynamic visual acuity is normal, so their VOR function is normal, but they are sensitive to motion, I might use a more habituation approach as opposed to prescribing gaze stability exercises to improve gaze stability. Now, in the traumatic brain injury, mild traumatic brain injury, post-concussion population, again, sometimes the vestibular approach depends on what their symptoms are and what their examination findings are. So if somebody has a concussion and also has a VOR impairment, we are going to do gaze stability exercises with them. That can push into dizziness a bit, but it depends on their tolerance level. At least I find when I'm treating people post-TBI, is we do need to push into the dizziness a little bit per their tolerance. We don't want it to be that we're knocking them out and they can't do anything the rest of the day and it's impeding their function, but we do need to find that balance of pushing into the dizziness a little bit. Just bringing on the symptoms doesn't mean immediately that we stop. We've got to gauge the patient's tolerance. And we also have to determine, are we approaching these exercises to improve their gaze stability because they have a true VOR deficit, or is it a more habituation building tolerance type approach? So I hope that has answered the question. Did I get all the parts? I think I did.
I think you did.
Okay.
Let us know. Oh, Jemana says thanks, so I think you did.
Okay.
I don't see any more questions in the chat or the Q&A at the moment. Please add your last. Oh, we've got one more. How does it affect the VOR testing and gaze training if a person does not have DR vision, meaning only focusing with one eye at a time? I'm not sure what DR means. Three-dimension.
Three-dimensional vision. Okay. So I have used gaze stability exercises, for example, in people who have monocular vision. So they have absent vision from one side, and you can do gaze stability exercise training even if they have those depth perception difficulties. I hope that's answered the question.
And here's one more. Two more. Can you explain VOR cancellation?
VOR cancellation. Okay. So VOR cancellation, we do in some circumstances need to suppress our vestibulo-ocular reflex. So remember, our vestibulo-ocular reflex is being able to move our eyes equal and opposite to head movement to keep our eyes on a fixed target. But if we are simultaneously moving our head, trying to keep our eyes on a target that's moving, we actually need to suppress the vestibulo-ocular reflex. So the example that I gave and how we test it clinically is having the patient hold their thumbs up, keep looking at your thumbs, and you turn your head and body side to side while you look at your thumbs. Now, to keep my eyes on target on my thumbs, I actually need to suppress my vestibulo-ocular reflex. So that is VOR cancellation. And an impairment of that, so if you have somebody do a VOR cancellation test, and their eyes don't stay on target, and as they move side to side, their eyes jump, there's this saccadic intrusions, that would be abnormal, and that would suggest a cerebellar involvement.
Well, we're at our time. Would you like to take one more question or wrap it up?
Sure, I'll take one more.
What is the acceptable time frame for dizziness after vestibular exercise? For example, as you've said, with exercise, it's acceptable to have some soreness for a day or so. For dizziness, what's the acceptable time frame that they will be slightly dizzy?
Yeah, so usually with gaze stability exercises, if we're trying to treat VOR impairment and improve VOR adaptation through gaze stability exercises, I might suggest to patients that they might feel slightly more dizzy than baseline for maybe 15 or 20 minutes after they've done the exercises. But we do want them to settle down to baseline levels relatively quickly. And if that's not happening, we need to adjust our exercise prescription. So it might be that we have them move their head for less duration, or we do shorter bursts more frequently during the day. So we need to really individualize our prescription to what the patient can tolerate. Now, if I'm prescribing exercises involving provoking movements from a habituation perspective, usually what I'm asking people to do is to do the provoking motion, bring on mild to moderate symptoms, and if it's for habituation, I would like their dizziness to settle to baseline levels within about a minute or two. So there can sometimes be some overlap in how we're prescribing those exercises, but if we divide it up that way, that would be my general rule of thumb. Again, individualizing that to the particular patient in front of me.
Thank you. I've just been asked to look at the follow-up question regarding the non-3D vision. I think there's some typos in here, so I'm not quite sure what Christine means. Binocular but not 3D, brain something suppressed 3D vision due to double vision in youth, so not 3D central. So
I am not sure that I'm the expert on three-dimensional vision and depth perception and all of that. So I think my answer to that is I don't really know, because I haven't run into that before, but I can certainly ask my neuro-ophthalmology colleagues to see if they have that information.
Well, we're just a little bit over our time. Thank you, Elizabeth, for this excellent presentation. You can see by the discussion that it really is something that people are interested in, and we haven't talked a lot about from in our regional stroke presentations in the past. So really great to have this. Thank you for allowing us to record this session. I will post it on the Central South website. in the next day or so, probably by the end of today. And Elizabeth is going to share some of our handouts or her slides with us, so I'll post that as well. I did put the link to the evaluation in the chat. I'll put it there one more time. We really appreciate your feedback, helps us know what else we should offer in the future. Please join us again. A week from today, we'll be having part 5 in our series about posterior stroke, and that will be with Dr. Katrina Steele, and talking about dysphagia or swallowing problems after posterior stroke. And then on December 7th, we'll have Dr. Vince DePaul talking to us about ataxia. Thank you once again, Elizabeth, and for the great presentation, and thank you all for joining. I'm going to stop the recording here, and please look for it on our website.